So, welcome everyone to the seventh webinar, the Comprehensive Neuroanatomy Educational Program, Module 4, Spine and Spinal Cord. This program is coordinated by the Yemeni Neurosurgical Society in collaboration with the WFNS Young Neurosurgery Forum, Pakistan Society of Neurosurgeons, Neurosurgery Couch, and Neurosurgical TV. Today, we have Professor Abhidha Shah. She is well-known professor, and she will talk today about okay. She will talk today about surgical anatomy and approaches of the craniovertebral junction. Professor Abhidha, she already participated with us in many webinars before, and in all her webinars, we all enjoy her presentations, and she gave very valuable information. So, Professor Abhidha, please, you can start.
Thank you, Ahmed, for this invitation and always being part of your programs. So, can you see my screen?
Yes, we can see it.
Okay, is it full screen now?
Yes, perfect.
Okay. Okay, so now let's move to the uppermost part of the spine in this spine module, and we will start with the surgical anatomy and approaches to the craniovertebral junction. So as you can see this image, the craniovertebral junction is a very complex structure because along with stability, it provides mobility, and also it gives passage to the most critical neurovascular structures. It is the transition zone where the spinal cord becomes, where the medulla becomes the spinal cord. This actually happens at this C1 level. So you can see this, the rootlet of C1, and this is where the medulla becomes the spinal cord, just at the level of the foramen magnum. So this junction is important. It is difficult to reach. It is a little complex to understand, but once the anatomy is understood, it is a very beautiful region to operate. So the craniovertebral junction or the posterior fossa is formed by this main bone, that is the occipital bone and the petrous part of the temporal bone. So you can see this is the foramen magnum. It is more broader in this anterior posterior aspect rather than the transverse aspect. The part of the occiput joins the sphenoid bone to form the clivus. Then the occipital bone forms the condyles that you can see here. The condyles will transmit the hypoglossal nerve, and the squamous part of the occipital bone forms a part of the occipital suboccipital bone and the posterior part of the foramen magnum rim. So here you can see the rim of the foramen magnum, and these are the large occipital condyle bones which articulate with the superior facet of atlas. And this atlanto-occipital joint is one of the most stable joints in the body. And it actually gives a lot of support to the head. It balances the head. The mobility of the craniovertebral junction occurs at this joint, which is the atlanto-axial joint. So you see this concave surface of the superior facet of the atlas. This is where the occipital condyle will sit and provide stability to the craniovertebral junction. And then the second joint in this area is the atlanto-axial joint, which provides most of the mobility of the craniovertebral junction. So you can see it is a combination of stability and mobility. Because of this unique thing, this joint is also most prone to instability. And now we will see in the presentation how this happens. So you see this is the C1 vertebra. Both C1 and C2 are atypical vertebrae. And you can see this is the C1 vertebra has no body. It has an anterior arch and a posterior arch, and it is flanked on either sides by the superior and inferior facets or the lateral masses. And you can see that the lateral mass of C1 is a huge, thick cortical bone, both because it has weight bearing and also because it supports the head completely on the occipito-atlantal joint. But this is an advantageous situation to us because this gives us a huge area when we have to fix the craniovertebral junction, and it gives us a very good purchase because it is a thick cortical bone. Also in this lateral part of the C1 is the transverse foramen, as you can see here. This is the C2 bone, which is also another atypical vertebra. Here you see the superior facet of C2, which articulates with the inferior facet of C1. Here you see the foramen transversarium is practically in the superior articular facet of C2. Sometimes there can be a high riding vertebral artery because of this. Then the more other important part is the facets of C2. They are not in line. So if you see in the subaxial spine, the facets of the cervical vertebra sit on each other. But in the C2, they are anterior posterior. They are not in one single line, and they are connected by this bone that is the pars. Here you can see the foramen transversarium as it is occupying a part of the superior facet of C2, and this is the thick C2 spinous process. So these are the most important bones of this region. Now let's layer by layer first look at the anatomy before we go to the abnormal problems at the craniovertebral junction. So when you start the dissection, you will start at this region. So you have the first layer of muscles, that is the trapezius and the sternocleidomastoid. Once you remove that, you will have the splenius capitis and then the semisplenius capitis. Here you can see they're attached at the nuchal lines and they go all the way down to the spinous process. Once you reflect this is the semispinalis capitis. Once you reflect this, you will reach the suboccipital muscles in the posterior aspect of the neck. Here you can see the muscles more clearly. You see the rectus capitis posterior major, rectus capitis posterior minor. Here is the superior oblique and the inferior oblique. And in the most lateral part, here you will have the rectus capitis lateralis. So the important point of these muscles is between this is a triangle, which is important for us to understand. And this is the suboccipital triangle. This triangle is formed by these muscles. So here you see this is the rectus. The most medial part is the rectus capitis posterior major. Just beneath that will be the minor. Then here you have the superior oblique that goes from the transverse process of C1 to the lateral part of the occiput. And here you have the inferior oblique. In this angle is the suboccipital triangle. And what are the contents of the suboccipital triangle? The main content is the vertebral artery as it runs on the posterior arch of the atlas. Then you have the dorsal ramus of C1, which also runs in this suboccipital triangle. And this whole triangle is covered by a venous plexus. So you see these blue structures here. So this whole area is covered by a blob of veins and it forms the venous plexus around this region. And that this area is the suboccipital triangle, which is important for our dissections. So here you see the rectus capitis posterior major, and here you see the minor. Here you see this muscle that is present laterally. You will see it more clearly here. Now you can see it. This is the rectus capitis lateralis. That is an important muscle. It is a landmark to where you have reached in the craniovertebral junction. This muscle is easy to identify. So now you see the posterior arch of C1. Here the vertebral artery is coming up from the C2, turning here, going on the superior first surface of C1, and then entering here on the medial surface of the occipitoatlantal joint to go intracranially. Here you see the venous plexus, and you will also see the C2 ganglion, as I will show you now further. So now we continue the dissection here. So now you can see the anatomy more nicely. So this is the muscle. This is the rectus lateralis. Okay, this is the C1. This is the C2. So you see the vertebral artery is coming out from here. It turns laterally and then loops over the C1, the posterior arch of C1 here, and then it enters the cranial cavity here, medial to the occipitoatlantal joint. So sometimes this, as you can see in this specimen, it gets this fibrous sheath gets covered and becomes osseous. So this is in this specimen it was there, and you can see the osseous ring that is formed around the vertebral artery as it enters the intracranial component. This is the C1 nerve root, and here coming out will be the C2 ganglion, which we will see now soon. So now you can see it more better. This is the C2 spinous process. This is the C2 lamina. This is the vertebral artery as it is coming out and then going above the C1. This is the C1. This structure that you see here is the C2 ganglion. So the C2 ganglion is the largest spinal ganglion, and it is second in size only to the fifth nerve ganglion. So here you see the C2 ganglion is it lies outside the spinal canal, and it occupies a position just dorsal to the atlantoaxial joint. So it is a very important landmark to reach the atlantoaxial joint. So here you can see that the C2 ganglion has been lifted up, and immediately you can see the C1, C2 articulation. So when Professor Goel described his technique of plate and screw fixation. Initially, we used to cut the C2 ganglion, and we called the C2 ganglion as a window to the atlantoaxial joint, because on cutting the ganglion, you immediately got access to the atlantoaxial articulation. Here, you're just laterally to it, you see the vertebral artery. Sometimes this vertebral artery has an anomalous course and it traverses just above the ganglion and it will enter the spinal canal from here. It happens in cases of, sometimes of assimilation of atlas, and that is when you have to be careful, otherwise you will damage the vertebral artery thinking it is the C2 ganglion. It is not difficult to mistake it during the surgery, but you have to look at the pulsations and then you will not mistake it. Now this is the midline view. Here you can see the C1 completely bared. This is the C2. This is the huge C2 spinous process which gives attachment to a big blob of muscles, and that's why it is when you're doing the surgery you have to disconnect all these muscles. Otherwise, they will not, your implant will not hold. This is the C2 ganglion, both the sides. Here you can see the C1, C2 joint. Here you can see the course of the vertebral artery. So as I said, it comes out from the C2, turns laterally, and then, and then turns medially over here again, and to enter over the posterior arch of C1, and then to enter into the cranial cavity. This is the rectus lateralis, rectus capitis lateralis. This is the branches of the C2 ganglion as it supplies the suboccipital muscles of the neck. Now here you can see on this side, the C1, C2 joint very nicely. Here, this is the lateral mass of C1, or the inferior facet of C1, and this is the superior facet of C2. This is the lamina of C2, and this is the pedicle. Here you can see that the C2 ganglion and the nerve root has been reflected medially. So here again on another side, you see sometimes you can take the ganglion up, you can reflect the ganglion down if you want to expose the C1, C2 joint. In very severe cases of basilar invagination, when you cannot have this view, that is the only time you need to cut the C2 ganglion. Otherwise, in majority of the cases, you can easily avoid cutting the ganglion. Now let's enter intracranially. So here you can see the occipital bone has been removed and the dura is opened. And now you can see the cerebellar surface. So here you can see that part of the occipital bone is removed. This is the region of the foramen magnum rim. And here you can see from an end-on view, the vertebral artery. This is the region of the occipito-atlantal joint, and the vertebral artery is entering inside the intracranial cavity in this region. Now you will see this more clearly. All the bone has been removed and now the dura is being opened. Before we go into that, here you can see the lower part of the cervical spine and the lamina has been exposed. You can see the nerve roots of the other spinal nerves that are coming out, and you can see all their ganglion are within the spinal canal. It is only the C2 ganglion that is outside the spinal canal. And here you can see the spinal cord as it is traversing across. Here you can again see the C2 ganglion and is supplied to the suboccipital muscles. Now you can see a closer view of the craniovertebral junction. Now this is the occipito-atlantal joint, and you can see the vertebral artery as it is entering here medial to the atlanto-occipital joint and entering the cranial cavity. Now the foramen magnum rim has been removed and you can see the spinal cord with all the nerve rootlets coming out of it. Here you can very clearly see the vertebral artery as it is entering. So this is a closer view. Now we can again see the vertebral artery coming out here. This is the most important arterial structure in this region because this is the one that is most likely to be damaged. I will show you tell you where it is likely to be damaged, but that's why you have to understand the anatomy of this artery very nicely. So this is the vertebral artery coming. Here you can see that it is looping laterally, then turning on itself, running on the posterior arch of atlas. Here going inside, turning medially. This is the occipito-atlantal joint, and then it becomes intracranial. So now you see this region here. So there is a thin filament-like structure that connects the spinal cord to the lateral aspect of the dura here, and that is the denticulate ligament. Here you see this nerve that is coming down, coming up from down, and that is the spinal accessory, and it will go up here to join the lower cranial nerve complex. Here you can see the jugular foramen with all the lower cranial nerves, and this is the exit of the facial nerve into the internal acoustic meatus. Again, this is a closer view. Now you can see beautifully the occipito-atlantal joint here, the vertebral artery entering medially to the atlanto-occipital joint. Here you can see the spinal accessory. It lies dorsal to the vertebral artery and it crosses the vertebral artery as it joins its cranial component here to enter into the jugular foramen. Just beneath this is the denticulate ligament. Here you can see this filamentous structure that is you can cut to get a some mobility of the spinal cord. That is the denticulate ligament. Here you see the C2 nerve roots as they're coming out and becoming the C2 ganglion. Here you can see the cerebellar tonsils, and you can see the caudal loop of the pica as it is turning, arising from the vertebral artery and going into the cerebellomedullary fissure. Now here you see the spinal cord with its rootlets more nicely. So you see the dorsal and the ventral roots meet here and come out to form the spinal ganglion. This whitish structure that you see here is the denticulate ligament. Now you can see it very nicely. Here you can also see it here. This is the denticulate ligament. Then these are the nerve roots of the lower part of the subaxial spine as they are coming out respectively in their corresponding vertebral areas. Again, coming to the C1 closer view of the C1 C2 joint, here you see how the nerves are meeting to form the C2 ganglion, and again giving an exposure just posterior to the C1 C2 joint. And now you see this joint very nicely as it is opened up, and this is the region that is most important when you're doing a C1 C2 fixation, as I will show you later when I show you the technique. Now this is just a repetition. I'll just go quickly. So this is the denticulate ligament, this is the spinal accessory, this is the vertebral artery, this is the pica, this is the nerve rootlets of the C2 as they are coming out. And I think we can just skip this. Here you can see actually rectus capitis lateralis. Here it is a guideline. As I told you, it's an important landmark. So what is an important landmark is when you dissect in this region, here you will see the internal carotid artery and the internal jugular vein in the anterior aspect of the rectus capitis lateralis. So this is a landmark. When you've reached here, then further dissection in this region will give exposure to the ICA and the IJV. Here you can see the internal jugular vein has been retracted here. And here you can see the course of the lower cranial nerves as they're coming down into the neck in this region. So the hypoglossal nerve and the lower cranial nerves will come here. So you have to imagine that this is in the anterior aspect of the neck, which we are seeing from posteriorly. So here you can see the cranial nerves coming out here and joining. This is the region of the carotid artery and the internal jugular vein. And here more posteriorly, you can see the relation of the lower cranial nerves and the hypoglossal nerve as it comes out in the anterior aspect of the neck. And this is a lateral view. Here you see this is the occipital artery, which is a branch of the external carotid artery and which we commonly use for bypass procedures. Here you can see that the muscles have been reflected, the obliques, the rectus lateralis. Here you can see the C1 and C2. And this is the exposure that we are used to when we are doing a retrosigmoid craniotomy. This is the sigmoid sinus as it is coming down to join the internal jugular vein. So this is the basic anatomy of the craniovertebral junction. Now, after seeing the anatomy, we have to understand what is abnormal in this region and how to approach this region. So first, let's start with the unstable spine or the unstable atlantoaxial joint. And this is the technique that actually revolutionized the treatment of craniovertebral junction anomaly. And the technique is this: you insert one screw in C1, one screw in C2, and both of them are joined together by a plate. And this is Professor Goel's technique of C1, C2 fixation. So it is a facetal fixation. It is a very strong method of fixation. And this treatment has actually changed the treatment of craniovertebral junction anomalies. So I'll just give you a good overview of that. So this is one of his first cases. And you can see the screw and plate constructs in this digital X-rays. Now you see this patient. So this is a mobile atlantoaxial dislocation. Here you can see on flexion, the atlantodental interval is increased. On extension, it is reducing, but not completely reducing. This is in a small child. Here you see the bifid anterior and posterior arches of the atlas. So in this situation, you see that the lateral masses of atlas is displaced laterally because of the, the bifid acts like a space to give the spinal cord so that there is no pressure on it, and the facets are displaced laterally. Here you can see the fixation and the implants and the reduction of the atlantoaxial dislocation. So the technique involves opening of the C1, C2 joint. So you put an osteotome in the C1, C2 joint, you open the osteotome, you denude the articular cartilage, you insert bone graft chips into the C1, C2 joint, and then you put a screw in C1 and you put a screw in C2. I will show you later in the presentation where the entry and exit points of these screws are. Now, after this technique of plate and screw fixation that Professor Goel described, on working on these anomalies, he realized that there is nothing like a fixed atlantoaxial dislocation. So even though on the X-ray it does not reduce, there is partial reduction only. Once you open the joint and maneuver it, you can completely reduce it. So there is no fixed atlantoaxial dislocation. You can maneuver the joint and make a fixed atlantoaxial dislocation, make it completely reducible. So the role of transoral surgery is completely questionable. So you see this patient, this is flexion. You can see this is an occipitalized atlas here. You can see the increase in atlantodental interval. This is extension. You see that there is some reduction, but not completely. But you see the position of the joints. The joints are abnormally inclined. The C1 is practically falling over the C2. Here there is also basilar invagination along with the irreducible atlantoaxial dislocation. But once you manipulate the joint and maneuver this area, you can actually straighten it out completely, and you can completely reduce the atlantoaxial dislocation and the basilar invagination and give a craniovertebral realignment. So there is nothing like a fixed AAD. It is completely reversible by manually manipulating the joints. So the whole treatment of craniovertebral junction anomalies revolves around the facets, and it is the facets that are most important in this region, and that will have a lot of role in the treatment of craniovertebral junction anomalies. So on treating these anomalies, we started treating basilar invagination. So Professor Goel in 2004 published this paper where he divided basilar invagination into two groups, Group A and Group B. In Group A, the odontoid went above the Wackenham's clival lines. It crossed the foramen magnum and it caused a compression of the cervicomedullary region. There could be a Chiari with it or there would not be. Chiari was not a criteria to divide the basilar invagination. And in group 2, in group B, the whole system moved up. The whole odontoid along with the craniovertebral junction moved up. There was a good incidence of platybasia, but the odontoid did not cross the Wackenham's clival line. So here you see the Chamberlain's line. The odontoid has gone over the Chamberlain line, but it has not crossed the Wackenham's clival line. So this is group B basilar invagination. So in this paper, it was recommended that for group A basilar invagination, you do distraction and fixation. So you open the joint, you fix the C1, C2 region, and you will have craniovertebral realignment. For group B at that time, he recommended foramen magnum decompression because the theory at that time was that the posterior fossa is compressed, is shortened, and because of the pressure here, there is cerebellar herniation, tonsillar herniation, and syringomyelia. But this theory has changed over the years, and at that time, foramen magnum decompression was the rule. But we only used bony foramen magnum decompression. The dura was not opened, nor were the cerebellar tonsils manipulated. So here you see, basically, basilar invagination is a problem with the joints. The joints are supposed to be actually lie one on the other, but in cases with basilar invagination, the inclination becomes abnormal. You can see here, this is falling slightly. Here you can see that here the C1 has completely in front of the C2 joint, and this situation is called spondyloptosis. Here you can see the abnormal inclination of the joints. So the whole theory of basilar invagination changed, where it was realized that it is not completely a congenital anomaly. It is mechanically unstable. The joints are abnormally inclined. They are not fixed. They are not only mobile, but they are hypermobile. And you can liken the basilar invagination to a lumbosacral listhesis. So just like the L5 falls over the S1, here the axis atlas falls over the axis, and we like to call it the odonto-occipital listhesis. So it is also the so-called basilar invagination. So this is basilar invagination is basically a mechanical problem, and it can be realigned by using distraction and fixation. So this is a patient that I've done recently. Here you can see the basilar invagination. In this patient, there was a slight Chiari. You can see how severe the basilar invagination is. Here you see the abnormal inclination of the joint. The C1 is practically over the C2. You can also see the course of the vertebral artery in this image here. You can see that it is going over here. It is just coming near the joint here. You can see it is an abnormal course. In this situation, there is an occipitalization of the atlas. So the artery is just entering here. So just beneath the joint, and it will come in your way, but you have to learn how to mobilize this artery. And here you can see that I've done a C1, C2 fixation, and you can see the reduction of the basilar invagination and the craniovertebral realignment, and this is the fixation. So the patient had a remarkable recovery and did well after the surgery. Is again another patient with a severe basilar invagination. You can see how close the joints have actually reached the occiput. So this is a very high basilar invagination and high location of the joints. But again, if you have to learn the art, you can actually do this. You can see that the joints have now straightened out, the basilar invagination is reduced, the craniovertebral junction is realigned, and of course the patient did well. This is again another patient with severe basilar invagination and completely malformed joints, but you can maneuver the joints. The trick is reaching the C1, C2 joint, opening the joint, manually, maneuvering the joints, keeping it in distraction, inserting bone chips, and then doing the fixation. Then you can cause the craniovertebral stabilization. So while doing this, we realized that a lot of this musculoskeletal changes in basilar invagination reversed after the fixation. So patients with a torticollis, patients with a short neck, immediately after the surgery, you can see that the length of the neck has increased, the torticollis has reversed. Again, you can see in this patient the torticollis and the short neck, the length increased and the torticollis has reversed. So we studied the neck in this paper, and we studied the reversal of all these musculoskeletal abnormalities in basilar invagination after the craniovertebral realignment and stabilization. And we realized that all of these are secondary protective phenomena that occur in the face of atlantoaxial instability. And once you address the atlantoaxial instability, all these changes have the potential to reverse and become normal. So based on this, the understanding evolved further that it is not just the atlantodental interval that is important when you're assessing the craniovertebral junction. You have to look at the facets, because the abnormality, the instability lies at the level of the facets. Based on this understanding, Dr. Goel devised this classification. So we now divide, apart from looking at the atlantodental interval, we also look at the C1, C2 joint and the facets here. So you see this is type 1, where the facet of atlas is in front of the facet of axis. So this is the regular one that we see in atlantoaxial, in clinically overt in atlantoaxial instability, where you see that there might be a change in atlantodental interval, and you see this type of facetal malalignment, where the facet of atlas is in front of the facet of axis. So this happens generally in acute instability or in patients with group A basilar invagination. So this is type 1. In type 2, the facet of atlas, it falls posterior to the facet of axis. Here you can see this is in neutral position, and the facet of atlas is behind the facet of axis. This is actually a part like a unilateral rotatory atlantoaxial instability, and you see it in patients with central atlantoaxial dislocation. So this is the next one is the type 3, where actually the facets are in alignment. There is no obvious instability in this region. There is no obvious change in the atlantodental intervality, but there are neural markers of atlantoaxial instability. And what are these neural markers? The presence of a Chiari formation and the presence of a syringomyelia. So all these, the presence of atlantoaxial assimilation of the atlas, the presence of basilar invagination, all these are indicators of chronic atlantoaxial instability, and that is what you have to look at. You have to look at the whole picture and see that there is chronic atlantoaxial instability in this region, and the treatment will be atlantoaxial fixation. So here you see the type 1, the type 2, and type 3, where the facets are actually in alignment. So this is the entity. So for type 1, is the regular atlantoaxial instability. For type 2 and type 3, we have called this as central atlantoaxial instability, because in these types, there may not be a change in atlantodental interval, but there are other markers that are suggestive of chronic atlantoaxial instability. And what are these markers? So if you see these markers, like a bifid arch of atlas, os odontoideum, you see short neck, short head or short body, you see basilar invagination, you see external syringomyelia, you see Chiari or syringomyelia, you see C2-3 fusion, clippal file, platybasia, kyphoscoliosis, and torticollis. All these markers point towards an chronic atlantoaxial instability and point towards the craniovertebral junction, whether you see a change in the atlantodental interval or not. So when you see this, you have to move your attention to the atlantoaxial joint and study the facets, and you might find that there is atlantoaxial instability in this region. So we reviewed our patients over 12 years, and we published this in 2023. Patients with central axial atlantoaxial dislocation, and those of who are interested can read this paper. We have divided central atlantoaxial instability into 3 types. This one is group A, where there are musculoskeletal and neural alterations that are primarily associated with the craniovertebral junction. Group B is when there is associated subaxial spinal instability. And group C is a very discrete group where there is no bony abnormality, there is no neural marker of atlantoaxial instability, but there are clinical parameters that are suggestive of involvement of the craniovertebral junction. And this is a very discrete group, and this I'm not going to cover this, but we have written a few papers on this subject. And this when you identify and treat, it completely changed the patient's life and the patient's outlook. A crippled patient suddenly has the potential of having a very normal life. So it is something that you have to understand, and maybe in some other lecture we can discuss that group C. So let's see the other types. So this is group A, central atlantoaxial instability. And what does it include? Group B, basilar invagination. So as I told you earlier, for group B basilar invagination, the earlier treatment that was advised was foramen magnum decompression. But as our understanding has evolved, we've realized that it is the atlantoaxial instability, chronic atlantoaxial instability, that is also the pathological factor in group B basilar invagination. So you see this, here you see that the odontoid is not crossing the Wackenheim-Schleifer line. It is crossing the Chamberlain's line. It is going beyond the rim of the foramen magnum. So this is group B basilar invagination. There is an associated Chiari. There is an associated syringomyelia. If you look at the joints, there is no abnormality here. The facets are in alignment. If you see the flexion extension, there is no change in the atlantodental interval. What have we done? We have done just a C1, C2 fixation. There is no foramen magnum decompression. And you see this MRI about 6 months after the surgery. The Chiari has become less. The syrinx has markedly reduced in size, and the patient did very well clinically. So you realize that it is atlantoaxial instability that lies at the heart of this group B basilar invagination. There is another patient with group B basilar invagination with Chiari, with syrinx. And here you can see the MRI a few months after the surgery. The Chiari is completely reversed. You see this one and you see this one. And the syrinx has also resolved substantially. And you see the facets. There is hardly any malalignment. This is a type 2 atlantoaxial facetal instability where the facet of atlas is behind the facet of axis. And all we have done is a C1, C2 fixation. This is again another patient with group B invagination, Chiari, syringomyelia, type 3 facetal instability, and we've done a C1, C2 fixation. You can see the resolution of the Chiari and the syringomyelia. Again, another patient with group B, Chiari and syrinx. You can see that the facets are in alignment. So you realize that we are treating the atlantoaxial instability, and you can see that there is a reversal of the Chiari and the syrinx. And more importantly, more than the radiological picture, it is the clinical picture that matters, and the patient improves in the immediate post-operative period. Moving on, so for group A, we said craniovertebral realignment and fixation. Now for group B, we are saying craniovertebral realignment and fixation and stabilization. Now coming to Chiari. So basically, basilar invagination, syringomyelia, and Chiari, they are all a spectrum of abnormalities at the craniovertebral junction. And the heart of these abnormalities is atlantoaxial instability. So this was our first paper in the subject. Is atlantoaxial instability the cause of Chiari malformation? This was our first series. And later on, some years back, we have published our observations in 388 surgical treated patients, where we have not done any foramen magnum decompression. We have just done a C1, C2 fixation. So here you see there is a Chiari. There is you can see the atlas, there is hardly any atlas assimilation. You can see the syringomyelia. You can see the type 2 facetal instability. We have just done a C1, C2 fixation, no foramen magnum decompression. Here you can see the syrinx has completely gone and the Chiari has also resolved and the patient has done well clinically. Again, another patient with Chiari and syringomyelia. There is no change in the atlantodental interval on flexion. You can see the type 2 facial instability. This is the C1, C2 fixation, complete resolution of the Chiari and just a very thin syrinx, near complete resolution of the syringomyelia. So you see this is, and clinically the results are even better. So the radiology just gives you a visual impression, but if you see the patients clinically, immediately in the post-operative period, they will improve. Again, another patient, here you see there is no bone abnormality in the craniovertebral junction. So, some would argue that, that there is some component of craniovertebral junction anomaly and that is atlantoaxial instability can be the reason in those cases. But you see this, there is no bone abnormality here. There is no change in the atlantodental interval. This is just a mild type 2 fascial instability. You see the Chiari and the syrinx, and we have just done a C1, C2 fixation, no foramen magnum decompression. You can see the resolution of the Chiari and the syringomyelia. So basically, Chiari is type 1. The Chiari 1 is related to atlantoaxial instability. Here again, another patient, you see there is no bony abnormality in the CV junction. This is a type 2 facetal instability. There's Chiari and syrinx, and after a C1, C2 procedure, you can see the syrinx has resolved, the Chiari has reversed. Again, another patient. Now we have countless examples, and I can keep on showing you slide after slide. I'm showing you the radiology, but believe me, the clinical is also better. In patients who have failed foramen magnum decompression, when patients do not do well after foramen magnum decompression, what can you offer? You can offer them C1, C2 fixation. We have done a few of our patients. We used to do foramen magnum decompression many years back, but they came back to us with complaints and we have treated them with C1, C2 fixation and they have done well following the surgery. We've also done monitoring of the transcranial MEPs following the surgery. So after tightening of the screws, so you see this patient has a Chiari and no, just a mild as a Chiari, the type 2 fascial instability. There is no change in the atlantodental interval on flexion extension. And after tightening the screws on both the sides, you saw there was a 30 to 40% change in the transcranial MEPs. That is a very significant change, and you can see how just atlantoaxial stabilization has caused this change in the MEP. Now, this is what we have come to now. See, a lot of people used to ask us, how can you say there is instability? Because we were just looking at the facets where sometimes there was no abnormality. So then we studied these patients and we started doing dynamic head imaging in all these patients. And now you see this is what we have seen, that all these patients with Chiari and group B basilar invagination have rotatory instability. So the rotatory instability may be complete or incomplete in the sense that the facet may be on one side affected and it may be better or normal on the other side, and sometimes it is present on both the sides. So now you see this patient with a Chiari and a small syrinx. The facets are in alignment. There is no change in the atlantodental interval. Now you see this rotatory imaging. You see how this side the facet is so posterior and on this side the facet is anterior. Okay, some amount of rotation may be normal in the C1, C2 joint, but here the C1 has practically come out of the C2 and this is definitely abnormal. And here you can see the fixation and patient did well. This again another patient where you see the rotate. You see this C1 is practically falling out of the C2. This cannot be normal. This is an abnormal mobility. This is rotatory atlantoaxial instability, which we are seeing in patients with our Chiari and group B basilar invaginations. And this is a definite indication of atlantoaxial instability. So you see in this patient again, how the C1 is practically fallen out of the C2. They are completely out of touch with each other. They are overhanging on each other. And here we've done a C1, C2 fixation and the patients have done well. Again, another patient with Chiari, syrinx, no other bone abnormality. And on dynamic imaging, we see this rotatory instability and we have treated it with C1, C2 fixation. Here you can see again the measure of the rotatory instability. So now coming to the technique. So now you can see that the indications of C1, C2 fixation have become very large because, for Chiari, it works. For group B basilar invagination, we can do it. So you have to learn the technique of C1, C2 fixation. And the most important things to understand when you're doing a C1, C2 fixation are there are 3 points. One is you have to understand the anatomy of the C2 ganglion. Second is you have to understand the anatomy of the vertebral artery. And the third point is you have to understand the venous plexuses. So the problems in C1, C2 fixation is that there will be a lot of venous bleeding in this area. Where does it occur? One, it occurs here in the epidural space. It happens more in patients with syringomyelia because there is a lot of fluid there and there is the veins are actually acting like a buffer. Then you get venous bleeding in this region of the vertebral artery, in the region of the C2 ganglion. And here, of course, we do not go, but this is the other venous plexus around the vertebral artery. So this is the deterrent to the CV junction surgery, because in patients with basilar invagination, Chiari and syrinx, you will have a lot of venous bleeding in the area and you have to learn how to manage that. The second thing is you have to expose the joint. In a straightforward case, it is okay to expose the C1, C2 joint. Otherwise, in severe basilar invagination, the view is obscured and sometimes you have to cut the C2 ganglion. And the third thing is the vertebral artery. Two things about the vertebral artery, that in cases of CV junction anomalies, it may have an abnormal course. So you have to know the course of the vertebral artery before planning the surgery. And second thing is you have to study the anatomy to see whether there is a high riding vertebral artery. So these are few of the important points while you're doing. Then comes the screw insertions. So because the vertebral artery can be high riding and be in close proximity to the superior facet of C2, it is in danger when you are putting the C2 screw. So in this paper, what Professor Goel did is he divided these parts of the C2 into 9 quadrants. And we found that even if there is a high riding vertebral artery, it never crosses beyond this point. So the most superior and medial quadrants of C2 are the idealmost region for the screw entry point of C2. Then you direct the screw insertion medially and cranially, and this is your trajectory of the C2 screw. In majority of these cases, you will not injure the vertebral artery. So here you can see the vertebral artery course as it is going here. So I will show you a high riding vertebral artery and how to mobilize it. So this is the technique. I'll just show you a few steps. So this is a 12-year-old child with neck pain, back pain, scoliosis. Here you can see the Chiari, the syringomyelia. You can see a mild atlantodental change in the atlantodental interval. This is flexion, this is extension. The facets are normal. This is the position. So we use a Gardner-Wells traction tong. We do not use any tongs preoperatively. It is used only intraoperatively mainly to stabilize the head. The incision is centered on the C2 spinous process. So you identify the C2 spinous process 4 centimeter above and 4 centimeter below. Then you open it, you separate the muscles by subperiosteal dissection. This is the C2 spinous process. Then you separate these tissues and you identify the lamina of C2. So this is the lamina of C2 and you trace the lamina of C2 into the pars and pedicle of C2. So once you start tracing this region, you can trace it and you will reach the C1, C2 joint. This is the tissues and the venous bleeding in the area that can cause trouble and you have to learn how to control it. So now in this situation, you can see that I'm operating this patient. I'm drilling the C2 pars region to actually make this region flat for my plate insertion, as you will see later. So this is another step that you can do. So going further, now here you see that this is the C1, C2 joint. Now you can see my osteotome in the C1, C2 joint. This is the facet of C1, the inferior facet of C1. This is the superior facet of C2. And now I'm inserting bone chips into the joint. So you can see I've opened the joint, I've denuded the cartilage. Now I'm inserting bone chips and then I will do the screw insertion. So once the bone chips are inserted, this is the region of C1 screw. So C1 screw, C1 is a large bone. So you have a lot of area to enter the C1 lateral mass. Generally the entry point is in the midpoint of the superior part here in this region of the lateral mass of C1. So you can see this. I've already made the hole. And then the direction is again medially and cranially towards the anterior arch of atlas. You put the C1 screw, then you rotate the plate and you have already drilled this area so that you can make the plate sit here snugly. And then you can make your C2 screw in the direction that I showed you in the most medial and superior part. And then you insert the C2 screw and tighten it completely. So this C2 screw is generally tightened first in cases of basilar invagination, and then the C1 screw is tightened. We use this plate and screw. We do not use the polyaxial methods because you can see this is a very stable, the plate actually sits on the bone and it gives a very stable construct. Here you can again see on the other side, this is the lamina and pedicle being traced, and here you can see that I've entered the C1, C2 joint. Here you can see the denuding of the articular cartilage. You can see some area, then again the screw insertion. So I'm going to go fast here. Now the screws are tightened on both sides, and the next important step is separating these muscles from the C2 spinous process. So now you can see how stable this region has become. You separate these muscles because the C2 spinous process, otherwise, your implant will be in danger. The muscles are so strong that it can actually pull your implant. So you want this whole region to fuse. You do not want any movement. You want zero movement in this area. That's why you detach all the muscles, and this is a very important step during the C1, C2 fixation. Then you denude this area and the host bone and put bone graft again on the posterior aspect of C1 and C2, and then that completes your fixation. So this is the regular method of C1, C2 fixation. We've also described the use of 3D printed models when the anatomy is abnormal. So here you see some anomalous courses of the vertebral artery as they're going in close proximity to the C1, C2 joints. And you have to study this anatomy because it will come in your way. A CT angio is also helpful in doing this. You don't need to make models every time. We use it only for complex situations. And we described this for the first time in literature. And in complex cases, it is very useful. So you can see in this how the vertebral artery is running on close proximity to the C1 lateral mass, the inferior facet. So you can injure it in this region. Here it is normal. So based on this, you can also decide which side you want to fix first. So here you can see we've studied this anatomy and done the fixation. Now this is what you call a high riding vertebral artery. So you see how the vertebral artery is going into the superior facet of C2. So how close it will be when you are wanting to insert a screw. And this can be injured when you're putting the C2 screw. So what is the solution to this? So you see this area becomes very less when it is a high riding vertebral artery. So in this situation, you have to mobilize the vertebral artery so that you can insert your C2 screw. So this is how it will be. The high riding vertebral artery will come all the way here into the superior facet. So you have to mobilize the artery out of this region, as you can see in this image, and then insert your C2 screw. I don't know if we'll have time for it, but I'll just show you quickly. So here you can see the C2 spinous process. This is here you can see that the vertebral artery is normal. So this case was operated by Professor Goel, and here you can see the vertebral artery in this one. It is on this side it is normal, on the other side it is high riding. So this is the first side. Now you can see on the opposite side, I'll just go quickly. Here you can see this is the vertebral artery. So you see how thin the pedicle here is, and this is the vertebral artery in the C2 foramen, transverse foramen, which is very high riding, and you have to mobilize it for inserting the C2 screw. So you can see that we have drilled it after inserting. Here you can see now C1 screw has been inserted, and now we want to put the C2 screw. You can see the pulsations of the vertebral artery here. So now we have to mobilize it. So you drill it a little bit. You make this part very thin, and then you just remove these bones around the vertebral artery. And then you can push the vertebral artery down, as you can see here. And then above that, do the C2 screw insertion. So you can see that the whole vertebral artery has been mobilized out of the foramen, and now the C2 screw hole is being made, and the C2 screw will be inserted just above the vertebral artery after mobilizing it out of the foramen. And that is the end of the procedure. And you can see the screw. It is so close here, but the vertebral artery is safe and it is mobilized out. And this is the post-operative patient. So we published this. This is again another patient where you can see how close proximity the C2 screw has to the vertebral artery. Here on the lateral aspect, this is how it will look, a high riding vertebral artery. But you can also identify it well on the coronal views. You can see this whole region of the vertebral artery and you can identify this high riding vertebral artery on the coronal angiograms. This is again another patient that we've operated. So the C2 spinous process, C2 vertebral bone is the key to the C1, C2 region. Now, sometimes there are no pedicles here, or the pedicle breaks, or some problem happens in this C2 and you're unable to put your screw in the C2 superior facet. So you must realize the C2 inferior facet is also a big, equally strong bone, and we use this technique as a salvage procedure. Sometimes when there is a problem in C2 screw insertion in the superior facet, you can insert the screw in the C2 inferior facet alone, or you can just take the C2-3 joint also in the construct and make it a stable construct. So you see in this patient, because of a very high riding vertebral artery, we could not do a C2 screw insertion, and we inserted it into the inferior facet. In this patient, the pedicles of C2 were completely absent. So you can see this is the vertebral artery. There is no pedicle of C2. So we put one screw in C1 and the other screw in the C2-3 region, C2-3 facet, which also gave a very good fixation. It's a very good stable fixation, and you can use it as a salvage procedure in sometimes when you have difficulty. This is again another technique that is described by Professor Goel. This is joint jamming. So sometimes it is difficult to, we don't use this technique anymore because we are able to do a C1, C2 fixation in majority of our patients. But sometimes you can just use a standalone spacer in the C1, C2 joint, and it fits snugly, and it also provides stability. So in this case where you see the vertebral artery was in the way on this side, so on one side we did a C1, C2 fixation. On the other side, we just inserted a spacer in the C1, C2 joint region, and that is also a very good stable construct. So that is joint jamming. Sometimes the basilar invagination is very high, and you have to make a little it's so high that it's difficult to reach this joint. So what you can do is just make a small opening in this region of the occiput on the lateral side, identify the facet from superiorly, and then you direct the screw into the C1 from a superior aspect. So here you see little bit of the foramen magnum rim and the occipital bone has been removed, and this is a transcranial insertion of the C1 facet screw, and you need it in very rarely in some cases of basilar invagination. Here you can see the trajectory of the screws. You can see how high that is. Basilar invagination is here, and that's why we had to resort to this. So we come from above and then identify the C1 and enter the C1 screw. This is again a salvage procedure which was described by Professor Goel long back, screw implantation in the spinous process for occipital fixation. We don't use this, but he had described it for the first time, and these are a few of his cases. Occipitocervical fixation, we do not perform it. I haven't performed occipital cervical fixation as of now, because we are always able to do some technique and manage a fixation of the C1, C2 region. For those of you who are interested, can read these articles on the subject. The craniovertebral junction is not just related to the C1, C2. There are also other pathologies. I'll quickly show you in 5 minutes, and then we can end it. This is again another entity that is important, a retroodontoid mass. So this tissue does not have to be removed transorally, does not have to be removed by doing a lateral approach or for coming from posteriorly. It is actually an indicator of craniovertebral instability. And here you see this tissue. This is a retroodontoid tissue just behind the C2, and you can see what we have done. It's actually a, the the ligament in this region is buckling, just like in rheumatoid arthritis, you have pannus. So it is buckled ligaments. And once you do a stabilization, this pannus or this retroodontoid tissue disappears. So it is an indicator of atlantoaxial instability. You don't need to maneuver this pannus. You just need to do a C1, C2 fixation, and the pannus will take care of itself. Another important tumor in this region. So now I'm coming out from the C1, C2 region. I'm coming out from mechanical bony pathologies to some tumors of the region. And here you see this is a C2 neurinoma. This is again another beautiful subject. You have to realize that the C2 ganglion is outside. So you do not need to open the dura while attacking the C2 ganglion or C2 neurinoma. You can do it without removing the bone. And those of who are interested can read our papers. We have divided it into 4 types. So A, B, combination of B and C. So, this is both intraspinal and extraspinal. This is just B type, which is just lying here, posterior to the atlantoaxial joint. This is going beyond the region of the transverse foramen and going laterally. So these are various types that we have described, but you can see that the procedure is very simple. You just expose the C2 spinous process. You can see the bulge here. You can see the bulge of the tumor in this region. We have not removed any bone. There is no bony removal here. You just open the region. You can see now we will approach the tumor. So here you see the whole bulge, because the whole ganglion is lying outside the spinal canal. So you do not need to open the dura or anything in this region. You can just open this capsule of the tumor, enter into it and dissect the whole tumor. It is a very result oriented and a very nice surgery to perform. It is quick, and the whole component, even this the component that is lying laterally and the component that is lying on the medial aspect will all come out in one go. And here you can see just some arachnoid is opened, which you can easily patch with a muscle, and the whole tumor can be removed without doing any kind of bone work. And this is a very nice surgery to perform, and of course very straightforward. So you can see this is a C2 neurinoma. So you have to identify that it is a C2 neurinoma and then doing the surgery. For foramen magnum tumors, for foramen magnum meningiomas, we use this conventional posterior suboccipital approach to remove these tumors, and I'll just show you a few examples. So you see this tumor lying completely ventral to the cervicomedullary junction. Both the vertebral arteries are in the way, and we've come from one side by using a posterior suboccipital approach and then remove this tumor. Just a few steps. So you can see the dural opening. Now you can see the anatomy that I showed you before. So this is the denticulate ligament that is being cut. This is the spinal accessory. This is the nerve roots of the spinal nerves, and here you can see the tumor between all these structures. It's quite a firm tumor. This is the cerebellum, this is the pica, the cerebellomedullary fissure. I will just go quickly for the want of time. So you see it's a quite firm tumor, but slowly you have to decompress it and reduce the bulk, and you have to learn how to handle the tumor. Sometimes you might need knife because it is quite a firm tumor. And then slowly you dissect and circumferentially come around. You reach the attachment, coagulate the attachment. This is the lower cranial nerves. Separated from these critical structures. So you see the cervicomedullary region has a very critical neurovascular structures that are going around it, and you have to avoid injury at all cost to them, because a disaster in this region. So if you have a complication in the craniovertebral region, you will have a conscious patient who is quadriplegic and probably on ventilator. And these are all benign problems. They will survive for quite some time. And it will be quite a disheartening thing to have a patient like this with you. So the complications are very disastrous. So you have to know the anatomy very well and then perform the surgery. So this is at the end. Here you see the vertebral artery as it is going. This is the pica coming out. This is the whole tumor that has been excised. We've gone right up to the clivus. You can see the vertebral artery here, and you can see the complete tumor removal from this conventional posterior fossa approach, which was also described by Professor Goel. Then there is another entity that is endodermal cyst. This is also a very nice tumor to operate. It is a very straightforward tumor, but you have to understand the anatomy and you have to recognize it preoperatively. So these tumors are hyperintense on T1 and hypointense on T2. So when you see a picture like this going on both sides of the cervicomedullary region, this is an endodermal cyst, and you have to just go in. The cyst is a very pus-like greenish color contents, and you can just remove it. If you have to leave some part of the capsule, it is fine. Don't cause any injury to the critical areas and nerves and vessels in this region, but remove all the contents, otherwise it can cause meningitis. So this is a few anomalies and tumors in the region of the craniovertebral junction. And I thank you very much for listening to me, and I'll be happy to answer any questions.
Thank you very much, Professor Abhidha, for this wonderful presentation and very nice cases. And I have a question, if possible. In cases of C1, C2 fixation, Do you use collar after surgery?
Do I use what?
Collar.
Collar, yes, yes. We
For
use
how
collar
long?
after. So at least for 6 to 8 weeks, so that the collar is just so that to remind the patient not to move the head, because you want that whole area to fuse. So the collar is just to remind him that he should not move his neck too much. But otherwise, it's a rigid fixation. So when they are just sitting around in the house or they're sleeping, we don't need a collar. But when they are mobile, we ask them to wear a collar.
Thank you very much. I see Dr. Ismail is already here. Dr. Ragnash Bahat, he has a question, I think. Please go ahead.
Thank you, Dr. Abhidha. This nice and informative presentation.
Thank you, Dr. Ismail. Thank you.
Thank you very much.
Do you have any comment, Dr. Ismail, or do you have any question?
No, it was a very nice and informative lecture, and this subject is very important. So Dr. Abhidha has covered this subject very well. Thank you.
Thank you. Thank you.
Dr.
Excellent
Ragnash Bahat.
presentation as always. And I didn't believe, I want to make a confession, I didn't believe that you could remove C2 neurofibroma without any bony work. But since I have done quite a few after Professor Goel visited us in 2016, I can say that it is possible. You don't need to remove any bone, and it is a wonderful surgery as you very rightly demonstrated. So I completely agree. Thank you very much.
Thank you. Thank you, sir. Nice to hear from you.
Anyone have any questions? Please, you can ask in the chat or you can raise hand. But as Dr. Ismail said, this lecture was very comprehensive and very detailed and has very, very nice explanation. So I don't think there will be much questions because everything was very clear and very nice. Thank you very much, Dr. Abhidha. We enjoy this lecture as all lectures you have before.
Thank you, Ahmad.
So I think there is no more questions. So by this, we can conclude our session. And we can see you all next week, inshallah, with more presentation. And very thank you to Dr. Abhidha Shah. She is a very, very wonderful neurosurgeon, and she has very, very nice presentations. And she supports us from the beginning of our program. So thank you very much, Dr. Abhidha, and thank you for this wonderful presentation.
Thank you. Thank you, Ahmad. See you. Bye.